Next is causes of clinical and therapeutic inertia. We have causes with reference to healthcare system, physician approach, as well as patient-related factors. So the clinical inertia is multifactorial. Addressing one factor alone is likely to have limited success. It is important that provided, patient, and healthcare system level barriers are considered together rather than as a separate problems. So the deliberate decision of opting for therapeutic inertia in a poorly controlled diabetic patients may aggravate early onset of diabetic complications. Very important, endangering the physician's ethical compliance with the non-maleficence principle. Next is prescribed number of doses per day is inversely associated with medication recurrence. So several studies were identified. Mean dose taking compliance was 71 plus or minus 17%. Compliance was significantly higher for once daily versus 3 times daily. More frequent dosing was associated with the lower compliance areas. So the prescribed number of doses per day is inversely related to compliance. This particular slide clearly shown the fact that taking 1 tablet a day improve compliance compared to patient taking 4 tablets a day. So the simpler, less frequent dosing regimens resulted in better compliance across a variety of therapeutic classes. Again, poor adherence translate into an increased risk of hospitalization and all-cause mortality. So poor adherence with reference to greater than 80% compared to 0 to 20%. 39% increased risk of all-cause mortality due to poor adherence. So better adherence linked to lessened risk of acute complication. Higher adherence was associated with the decreased acute care cost. At the same time, higher adherence rate increases the cost of the therapy, but you need to compare the value beyond the cost of the therapy in terms of other cost categories. So medication on adherence is common. It is not directly assessed by clinicians. The under-recognition of medication non-adherence can have adverse consequences. Patient may have poor glycemic control. We may think in terms of therapeutic ineffectiveness. We may increase the dose of the therapeutic tablets. It can precipitate an event of hypoglycemia. So the assessment of medication non-adherence should be incorporated into routine clinical practice. So the influence of financial strain on health decision making, patient lacking financial resources, dysfunctional healthcare systems, medication accessibility, as well as medication non-adherence. CGM is great, but should every patient with diabetes have a CGM? However, accessibility and utility depend on 3 questions. Will my patient be able to afford it? Is my patient willing to buy a CGM? Is my office ready to take full advantage of that wealth of information CGM can offer? So identifying the right person for CGM. Insulin treated individuals, pregnant women with frequent hypo, type 2 on intensive insulin therapy, poorly managed diabetes from understanding the influence of diet, activity and medication on glycemic parameters. So challenges in implementing time in range as a glucose metric, high cost of CGM, unavailability of the more accurate devices, barriers to uptake include the cost, the technical issues, human factors, absence of standardized format, and lack of understanding or a consensus. So next is ethical considerations in the treatment of childhood obesity. We have pharmacotherapy, family-based therapy, bariatric therapy. Of course, this was highlighted by Dr. Vinay. So it is prudent to employ family-based therapy, very important. When this particular therapy is not proved effective, we need to look for other, namely pharmacotherapy or bariatric therapy. Can we suggest bariatric therapy for childhood obesity? Though it carries very good improvement with reference to metabolic parameters. So the pharmacological agents to treat obesity in young, we have the orlistat, sibutramine, liraglutide, semaglutide. This was highlighted by Vinay. So the lifestyle, diet and exercise changes should all be implemented in conjunction with the medication, and families are encouraged to be involved to better increase the chances of sustainable weight loss in obese adolescents. So A1C goals must be individualized and reassessed over time for children and adolescents. So keeping A1C less than 7 appropriate for many children and adolescents. Less stringent A1C goal, that is keeping it below 7.5. In certain categories of patients, so also maintaining A1C less than 8%. So ADA recommendations with reference to obese individual, especially in young age group with increased risk for type 2 diabetes management. So we have drugs and maximize non-insulin therapies depending upon the A1C value less than 8.5, more than 8.5, or if the patient presents with the DKA or HONC. Should we consider metabolic surgery in obese individuals? So the data from STAMPEDE clearly shown bariatric surgery versus intensive medical therapy for diabetic patients, 5-year outcome. So if you look into the glycated hemoglobin, there was significant reduction among those patients who had undergone bariatric surgery plus intensive medical therapy. Equally important, diabetes medication. Several patients, the therapy was withdrawn. So 5-year outcome data showed that among patients with type 2 and a BMI of 27 to 43, bariatric surgery plus intensive medical therapy was more effective than intensive medical therapy. ADA 2024 considered metabolic surgery as a weight and glycemic management approach in patients with diabetes with a BMI of greater than 30. So bariatric surgery should be considered in obese children. Metabolic surgery may be considered for the treatment of adolescents with the type 2 who have class 2 obesity or higher BMI. Very important. Right. So parents and decision makers, we the physician should sit by the side of the parent or the caregiver and explain clearly the benefits and the risk. And the child should also understand the surgery, the procedures, the risk and the complications associated with it. Support from healthcare professionals through the decision-making process for treatment is beneficial. So treating older adults. So older adults with the diabetes should annually update the list of used medications. So Dutch study showed that is type 2 patients aged more than 70 years were overtreated and frail. 1/4 of US older are diabetic patients. Tight glycemic control, they are at high risk of hypoglycemia. So optimal glycemic target, older adults with few existing chronic illnesses and intact cognitive function should have low glycemic target. On the other hand, those with multiple coexisting chronic illnesses, cognitive impairment or functional dependence should have less stringent glycemic goal. So no improvement in cardiovascular outcome by achieving tight glycemic control, data from ACCORD, ADVANCE and BADT. So is it stringent A1C target always? It is an agreement on tailoring glycemic goals in function, that is depending upon the functions of the patient's life expectancy, diabetes duration, functional status and existing comorbidities. In old diabetic patients, frailty or at risk of hypoglycemia, a target of greater than 50% TIR with less than 1% TBR is now recommended. Addressing MASLD, in fact, it was nicely pointed out by Amit also. So steatotic liver disease, cardiovascular risk factors. Very important thing is diagnosing a condition for which there is no effective treatment. Potential harms of diagnosing the disease in health. Variability in specialist attitude to discussing and managing obesity. So the complex, it gets making the patient understand the issue. NAFLD, increased events and increased mortality. These are the diagnostic criteria. Next is, what is the name? So we have the NAFLD, we have the MASLD, we have the MAFLD. So 3 important parameters, depending upon whether the patient is taking alcohol or not. So exclude any other causes, include alcohol intake also. So the 3 conditions involve the accumulation of fat in the liver. But while NAFLD is characterized by the absence of significant alcohol intake, MAFLD and MASLD encompass a broader spectrum regardless of BMI or alcohol intake. So NAFLD, a silent killer, so early diagnosis is much more needed, non-invasive test to detect NAFLD, right? Next, considering a liver biopsy, that is a gold standard. Its role has been controversial. Indication, diagnostic, and also to permit inclusion clinical criteria. Just to include in clinical criteria, should be subject our patient for liver biopsy, or else we can straight away put the patient empirically on other medicines. So considering a liver biopsy, a biopsy is taken for research and clinical trials raise ethical questions. So the general consensus is that it is reserved in cases with uncertain diagnosis or to confirm advanced liver fibrosis. So weight loss, 5 to 10% associated with improvement in liver function and histological features. So main drugs and targets in NASH treatment. FDA approves resmetirom, first treatment for patients with liver scarring due to fatty liver disease. Cost, availability, cost effective. We need a molecule which addresses diabetic dyslipidemia, diabetes mellitus, NAFLD, NASH. So what is needed in the management? GLP-4 agonist. We have the primary alpha effect on lipid metabolism, gamma effect on glucose metabolism. So evolution of saraglitazar from anti-dyslipidemic, anti-diabetic to the management of NASH and NAFLT. So saraglitazar are prospective observational studies clearly shown improvement with reference to liver parameters. So this particular evidence for multicenter randomized trial, placebo-controlled phase 2 study clearly shown the benefit. So the role of saraglitazar. Next is bariatric surgery resolves NASH. And is bariatric surgery for obesity in children justified? Of course, in selected category. These are all the ethical issues and challenges associated with the non-alcoholic fatty liver disease and potential solution. So, application of principles of ethics in a patient care with reference to clinical assessment, patient rights and preferences, quality of life, external forces and context. So, it's an integrated model of patient care, knowledge skills as well as practice-based learning skills. So, the medical knowledge, skills to apply that knowledge, technical skills, practice-based learning and communication are partnered with ethical principles. These are the physician's obligations. Cure of a disease when possible. Maintenance or improvement of functional status. Prevention of disease and prevention of untimely death. Conclusion, in all interaction with the patients, besides the technical expertise of a physician, the human element of caring is needed. Manner of communication with both physician and patient, closely seated and with unhurried, softly spoken words. Gentle touch, especially when conveying bad news. Firmer touch or grip to convey reassurance to a patient facing a difficult treatment choice. Hold the hand of a patient dying alone. Right. Thus, caring is in the center of the depicted integrated model, and as Peabody succinctly expressed it nearly 100 years ago, the secret of the care of the patient is caring for the patient. Thank you very much for your kind listening. So, on behalf of the organizing committee of National RSS Day, I request all our delegates to register and make this a memorable one. Thank you very much.
Over in the limited given up time. Now we have enough time for question, answer and interaction, comment. I will start. How the ethical issue merges with negligence and then to criminality?
It's a very big topic, and discussing it in this particular forum, giving 1 minute to answer this, it's a very, so negligence is different and our ethical principle is different. So we are approaching our patient to benefit the patient, not to do harm, and also to promote the welfare. Negligence mainly on the part of the treating doctor. Yes,
anybody from the audience? Comments? Some update?
Legal.
And ethical is not law. Ethic is ethics.
Now suppose
So
there is a
do you
guy.
think, sir, beneficence and maleficence comes hand in hand?
No, sir. No. I don't think.
So can you explain? So?
I don't think.
Suppose a child of 17 years.
Pardon, sir?
Suppose a child of 17 years.
Yes, sir.
Parent give consent for bariatric surgery.
Yes, sir. Yes, sir. I understand.
And at 25, he develops certain serious complication.
Yes, sir.
Now he is adult.
Yes, sir.
What does it mean later?
And the thing is, I told you, so discuss the surgical procedure and see whether this particular patient, 17 years, can understand the surgical procedures, the advantages, the disadvantages, and the risk associated, including the post-surgical follow-up, everything very clearly. You are the treating doctor and you are going to decide about whether this particular patient capacity can understand all these things. In the absence of it, you are explaining everything clearly to the patient's parents. Based on the patient's parents' willingness, you have taken the patient for surgery. After 7 years, patient develops complications. It doesn't come under, sir.
There is enough time if anybody wants to still. Yes.
We should offer the guideline-based and evidence-based treatment. That is how we can comply with the law.
No, my problem is, suppose parent give consent.
No, but whether a 17-year-old boy or girl is benefiting for bariatric surgery, is there any evidence to that? And is it in the guideline?
At that time.
Is it in the guideline?
Because evidence are changing.
Yes.
The judgment will depend on that only. What was the,
That time.
not
At the
after
time,
7
the
years.
guidelines clearly
Guide-
mentioned
yes.
there was evidence, and this was clearly explained by the treating doctor to the patient as well as to the patient caregiver.
And see,
And
as far
based
as-
on their acceptance, it was carried out.
See, lawyers can take advantage on both sides.
Yes, yes.
So it's a legal issue.
So how you argue is
No,
important.
but the important thing is that if the guideline says yes, then you are not at fault.
You are justified.
Yeah.
So initially, we have done benefit to the patient.
See, sir, the best example is the COVID. You see, it was treated globally with HCQ, hydroxychloroquine. Later, it was found not effective. But it does not mean the patients during that duration were treated with HCQs can sue a doctor or hospital. It's not so.
Forget about 7 years of post-surgical follow-up, sir. Meantime, the patient might have developed some other complication because of the obesity.
Anybody have any question for the first speaker? Then also welcome.
Sir, I have a very simple situation which I faced recently. A young girl was being treated for PCOS,
Okay.
and 2 years back, her USG was suggestive of PCOS. 2 years later, she developed dermoid teratoma in the ovaries, and almost both the ovaries, one after the other, got removed. Now, how are you going to put this
Yes,
in this scenario?
because it was not given timely treatment.
Exactly. Now, you don't know 2 years back, which was
What
a
will happen?
polycystic disease, was a ongoing teratoma which was happening because no CT was done. It's a very common situation. So people think it was a PCOS, isn't it? And they start treating metformin and spironolactone and all those stuff. But 2 years later, there was a big tumor. It's almost a tumor of the size of 10 centimeter. So you can imagine what has gone wrong with the child. It's not child, it's 18, 19 years old girl. Now she was operated on both the ovaries, and she's been told that she's not going to conceive later on. How do you
So patient might say the disease is aggravated iatrogenically.
No, sir. I don't know what the patient will say. But what I'm saying, the scenario, what you all are discussing, falls into this picture.
Correct.
And you don't have answer 2 years before and 2 years later.
Yes, yes. Right treatment and the right
And
choice.
she had the ultrasound with her 2 years before. And it was done in Bangalore in a very big institute, sir. Not Chota Mota Institute,
Yes, yes.
Manipal Hospital. So the thing
Sir-
is, there is a possibility that the diagnosis which has been done is more commoner first. The rare comes later on. And if the
Right.
patient doesn't have symptoms, you don't start poking up the diagnosis to the last extent.
In certain situation, is it advisable to take one more opinion?
Sir, one more opinion if you have problems, no. But you don't have any complaints. Why will you have second opinion?
Okay.
Unless you have a problem.
Sir, are you talking about medical negligence?
I'm not saying medical negligence or ethics or anything, sir. What I'm saying is this is a clinical scenario, sir.
Yeah. It happens, and to be honest, I am a law graduate. First I confirmed. I have done MD, MRCP, and I am LLB from a recognized university. And there are two entities. One is called medical negligence. One is called medical error. And this was a diagnostic dilemma which we are talking about. It is never a negligence. And whenever we fall in diagnostic dilemma, you are always on the safe side. Because what you have just pointed out, that the patient did not have symptom and there were no indication for further follow-up. What the gentleman was telling about the evidence-based medicine. So here the law is clear, and people in newspapers we always see negligence. Negligence is a big term, and medical error is a different. Negligence, to put someone in negligence, you need to prove that he has done something willfully or unwillfully which should not have been done by him. Am I clear?
Here again there
Can I
are two
comment?
aspects, sir.
Can I
Yes,
comment?
So here again there are two perspectives. First perspective is the initial problem is started by the media and the press,
Yes.
which doesn't believe in evidence-based or guidelines-based. They will spoil you for the next 15 to 20 days in each and everywhere. then later on you keep fighting in the court and defending yourself. That comes after 5 years' time. So what happens to you is in this 5 years is a very, very difficult
Yeah, I can jolly well understand this is the media trial we are talking about. That's why I am telling this.
And the media trial is more of emotional
Yes.
connect with the people, sir.
Yes.
And not with the logic and
That's
the science
why
behind
I
it.
am telling you that we must know about law. Every doctor should know about law, their rights. We must talk about this. We should have sessions about this. And what we are just talking about, ethics is a part of law. And in our curriculum, in our days, it was not there. Now we have a revised curriculum. I teach in a medical college. Many of us teach in a medical college, including Dr. Boido. And ATCOM is, we call about attitude, ethics and communication. We teach it from first year. And this is one of the major features in developed countries. I have done MRCP. There are communication skills that are tested, there are ethical issues that are tested, and we have introduced it. Now we are in a better position to teach our people, to teach our students, and we should also learn this. We should talk about this. And the media trial, what they can do, we also can answer properly. And this, if you can answer properly, the people will not take you for granted that you have done this, you have done this. And we must sue. I also belong to an organization. We have an organization that works for the doctors, West Bengal Doctors Forum. That is not a talk of day. But we should always talk about our fellow colleagues together in a raised voice that what is medical error and what is medical negligence. This is a very well, nicely pointed out.
Can
Sir.
I comment? So I think the ultrasonography which was done before, if the morphology or the sonographic morphology of the ovarian morphology was clear-cut fitting with the morphology of polycystic ovarian syndrome, so that the later finding could be a new development. So it has nothing to do with the previous one. So
Not actually saying in the perspective of medical negligence or medical error. What I am trying to correlate is, when you talk about all these things, sir, the clinical acumen completely changes and the general people don't understand this.
Yeah, he's talking about media
This is what I am
trials.
saying, sir.
Yes.
I am not saying regarding any negligence.
You are
I
quite
didn't
right,
say
sir.
anyway, sir. What I am trying to say, sir, there are a lot of clinical cases where nothing works. There is a total different dilemma which is happening with the patient, and you cannot correlate what is happening.
So I believe the second finding was confirmed by the histopathology. after
Yes, sir. Yes,
surgery.
sir. If both the ovaries were sent for histopathology,
That could be a new development,
even
new
malignancy was
pathology.
ruled up, and it was a teratoma.
Yes.
But
So,
to
Dr.
remove,
Otherwise, if it was a case of big cyst, that could be on the background of polycystic ovarian syndrome, which we called hypertrichosis of ovary.
So, Dr. Velu, very interesting topic.
Thank you,
We
sir.
generated a lot of discussion,
Yes, sir.
and probably it will go on.
Definitely, sir.
So, thank you very much.
Thank you so much. Thanks a lot.
So, we conclude the session.
Now I request Vinay sir and Velu sir to join us for the photo session.
Good evening, ladies and gentlemen. We move on to the next symposium. This symposium is a mixed bag in diabetes management and diabetes treatment. We are very unfortunate and that Dr. Amod Sachan could not come to this conference because of a regulation from the UP government to be present at all the medical colleges today due to MCI NMC visit. Our speaker will be Dr. Vinod Abhichandani and Dr. Ghanshyam Goyal. I call upon the stage the chairpersons of this session, Dr. Muhammad Riaz, Dr. A.K. Ojha, and Dr. P.C. Hajra. Sir, please take your seats as a chairperson and start the deliberation and after introducing the speakers.
I welcome Dr. Vinod Abhichandani sir on the dais. The sir will be speaking on topic mental health and metabolic disorder, exploring the bidirectional relationship. So the forum is open for you. Dr. Vinod Abhichandani sir is a well-known speaker, so everyone knows about sir, like he is a well-known diabetologist and endocrinologist. Sir practices a lot of diabetes and endocrine disorders, and he has a vast experience in explaining in regards to the mental health. So I hand over the forum to you, sir. Please go ahead, sir.
Thank you very much, honorable chairpersons and all esteemed colleagues. Over the next 18 to 20 minutes, I am going to explore the bidirectional relationship between mental health and metabolic disorders. So, what is the prevalence of comorbidity between mental and medical conditions? If you look at this particular slide, you will find people with mental disorders, almost 25% of adult population is suffering from mental disorders. Another 58% of adult population is suffering from medical conditions. And if you look at the people suffering from mental disorders, almost 68% of adults with mental disorders have medical conditions. So, yes, this is working. And 29% of adults with medical conditions have mental disorders. So, let me politely remind you that this is a 2-decade-old statistics, and nothing has improved so far. In fact, things have worsened, and if you are able to project today's scenario, it would be worse off. So, physical and or psychological stress associated with systemic illness can lead to activation of immune response system, resulting in increased local and systemic release of pro-inflammatory cytokines. So, here we are looking at the physiological and psychological and physiological stress due to systemic or physical illness, immune inflammatory response activation, and lot of outpouring of pro-inflammatory cytokines. So, increased levels of inflammatory mediators in the CNS are potentially key contributors to the damaging cellular and morphological adaptations that underlie the development of finally the psychological illnesses or comorbid mental illnesses. So, chronic low-grade inflammation, which is a hallmark of numerous chronic conditions such as metabolic disorder, is defined by the persistent presence of elevated levels of circulating pro-inflammatory cytokines like interleukin-6, tumor necrosis factor, interleukin-1 beta, and acute phase reactants like CRP. Common signs and symptoms that develop during chronic inflammation include depressive mood and chronic fatigue. So, are people with diabetes at higher risk for psychiatric disorders? I believe they are, and in order to drive home this point, I am going to present a short case. Mr. R.A., a 52-year-old married man, is seen by his PCP, that is primary care physician, for scheduled care of diabetes. He was diagnosed 4 years ago with type 2 diabetes. He is obese with a BMI of 30.4 and hypertensive with a recorded current BP of 166/92 millimeter mercury, but otherwise has no evidence of coronary heart disease or other complications of diabetes. And despite using insulin, his hyperglycemia remains uncontrolled. His recent HbA1c was 10%, and he rarely monitors his sugars at home. 6 months ago, the patient started having difficulty falling and staying asleep. As a result, he felt tired and fatigued most of the time. He became less physically active, stopped exercising or socializing, lost interest in almost everything including sexual activity, and gained 6 kgs of weight. During this time, however, when he was questioned, he earnestly denied feeling sad or depressed. He has continued to work but has trouble concentrating, frequently forgets things, and feels impatient, irritable, and frustrated. For the past month, the constellation of symptoms has been persistent, increasing, and interfering in his daily activities of life. So, can a diagnosis of depression be established? The diagnosis of depression or major depressive disorder can be established even though the patient does not feel depressed or gloomy. Depression in persons with diabetes can be diagnosed in the absence of sadness. Loss of interest, including social withdrawal and irritability, are the most prominent features of this non-dysphoric presentation of depression. Diabetes doubles the likelihood of comorbid depression, making it present in almost 20% of all patients with either type 1 or type 2 diabetes. The risk for coronary heart disease has been measured as being at least 3 times greater in depressed ladies with diabetes compared to non-diabetic ladies. So that is the morbidity strength of diabetes. And pharmacotherapy and counseling are viable treatment options. We must remember that depression in diabetes is a chronic condition. Recurrent episodes requiring treatment are the norm and not the exception. Restoring mental health improves glycemic control and has ancillary beneficial effects on sleep, appetite, mentation, and physical, social, and sexual functioning. So, looking at the factors which act as a bridge between type 2 diabetes and all listed mental disorders, there are many factors which are continuously making sure the two ailments remain connected. The factors include genetic factors like in utero development, environmental factors, certain biological factors like inflammation, immune dysfunction, oxidative stress, HPA axis dysregulation, impaired insulin signaling, gut-brain axis dysregulation, fat-brain axis dysregulation, and overall endothelial dysfunction. Then behavior problems, sedentary lifestyle, indiscrete diet, sleep disturbances, and the burden of getting diagnosed with type 2 diabetes is very overpowering. That burden can itself trigger a mental issue, and the poor treatment adherence would be a fallout of that burden. And certain medications can also contribute, antipsychotics and antidepressants. So what is the role of mental disorders in precision medicine for diabetes? If you go from top to bottom, it has a role in prevention. Mental disorders contribute to diabetes development. We are all aware of this. Hence, and also additionally aware that mental disorders continue to contribute to poorer diabetes outcomes. That's number 2, prognosis. And at number 3 is treatment. So if we offer treatment for all mental disorders, we could possibly end up with fewer diabetes patients and probably in established diabetics with better outcomes. And in current era of modern science, using smart solutions to assess mental disorders could improve diabetes care and prevention. Now, looking at metabolic syndrome and mental health issues, so there are some common risk factors for metabolic syndrome in chronic psychiatric illness, and these include food imbalance and poor dietary habits, genetic predisposition, hormonal imbalances involving mainly cortisol and leptin, second generation antipsychotics and their related side effects. At the bottom I have listed few of the second generation or the atypical antipsychotics, and then sedentary lifestyle. And in fact, metabolic syndrome tends to be associated with certain characteristics of bipolar disorder. What are these characteristics? Longer duration of bipolar disorder, especially type 1. For those of you who are interested, bipolar 1 disorder is defined by manic episodes that last for at least 7 days, nearly every day for most of the day. And more lifetime manic and depressive episodes, more severe first affective episode, late onset of first manic episode, and late age at first treatment for manic or depressive episodes. And there is another term coming up in the next slide, and experiencing 4 or more episodes of mania or depression within 1 year is called rapid cycling. So individuals with bipolar disorder who have diabetes mellitus are more or MATS are more likely to experience rapid cycling, lower level of functioning, and more psychiatric hospital admissions than those without diabetes or MATS. High rates of lifetime suicide attempts in patients with bipolar disorder. So literally bipolar disorders are driven to suicidal tendencies, especially when they have accompanying metabolic syndrome. What about obesity? Obesity amplifies risk of mental disorders like depression, anxiety, psychosis, and more. So what is the link? Inflammation is a major link which perpetuates the cycle, adiposity, overweight, or obesity, turning into depression for that gentleman, especially with atypical features. And unless we interrupt this cycle, the end result will be a host of CV and metabolic comorbidities like cardiovascular disease, cerebrovascular accidents, metabolic syndrome, and type 2 diabetes. So overweight and obesity is associated with low-grade inflammation originating from the adipose tissue and changes in gut microbiota composition. So immune to brain communication leads to the activation of brain inflammatory processes responsible for substantial changes in brain function, including alterations in I'm sorry for the font size, I couldn't enlarge them, including alterations in neurotransmitter biosynthesis, that is here, and changes in neurogenesis and synaptic plasticity. That's on the right. Concomitantly, brain cytokines promotes neurotoxicity through activation of glutamate pathways, that is in the center. Altogether, these alterations contribute to the development of depressive symptoms in patients who are obese or overweight. And coming to dysbiosis, the linking role of microbiome dysbiosis is outlined in this slide. Human-associated microbiome plays an important role in the interplay between immune and energy dysregulation, linking atypical depressive symptoms to comorbid metabolic disorders. Atypical depression, just for the setting it on paper, I have included this definition. Atypical depression is a type of depression in which one experiences a temporary boost in mood in response to positive events. Other symptoms which are peculiar to atypical depression include increased appetite, hypersomnia, and rejection sensitivity. It's treatable with psychotherapy and antidepressants. Dysfunctional interplay among microbiome composition, immunity, and metabolism that predisposes to atypical depression, we just saw in the previous slide, and cardiometabolic disorders may occur early in the development. Dysbiosis of the oral microbiome facilitates the passage of pathogenic microbes and their metabolites across the blood-brain barrier and may affect neuronal function. Now we'll look at the intersection of mental illness and cardiometabolic disease. So, looking to the right side of the cartoon, early life stress is a known risk factor for major depressive disorder and related metabolic disorders. Given that MDD patients with atypical features tend to be younger, there may be a strong interrelationship between the development and maturation of microbiome, that is microbiome dysbiosis, immune system, and central nervous system. So immune maturation, neurodevelopment, all are impacted, leading to HPA axis dysregulation, chronic low-grade inflammation, neuroendocrine dysregulation, ultimately culminating into cardiometabolic disorders and major depressive disorder in the same unfortunate person. So people with SMI have a life expectancy approximately 15 to 25 years shorter than the general population, with most of the excess premature deaths occurring due to cardiovascular disease. And people with schizophrenia, bipolar disorder, and major depression have a higher prevalence of modifiable, please remember this, we can really change the picture if we are able to counsel the patient correctly. Cardiovascular risk behaviors and conditions, and twice the cardiovascular mortality rate of general population. So why that is that high? Because the excess cardiovascular disease related mortality in people with severe mental illness is caused by a variety of factors, including a high prevalence of nearly all modifiable cardiovascular behaviors and conditions. They are listed here: hypertension, diabetes, dyslipidemia, MAT, smoking, obesity, sedentary lifestyle. And disparities in access and quality of care at every step, there is a disparity. Psychopharmacotherapy and direct effects of any illness, the main illness and any comorbidity. Now, approaching the end of my presentation, relationship between nutrition, metabolic and mental health. So food and mood, is there a connection? So a 2014 study in brain, behavior and immunity that used data from the Nurses Health Study did find an association between depression and a diet rich in sugar-sweetened soft drinks, refined grains, and red meat. Modifiable lifestyle factors such as dietary choices, smoking, and physical activity could potentially affect both depression and metabolic disorder risk. A 2018 meta-analysis published in European Journal of Nutrition suggested that high consumption of meat could be associated with risk of developing depression. In no way I am against non-vegetarianism. Please don't misunderstand me, but when anything is done in excess, it is detrimental to the health. So, we look at the 6 pillars of lifestyle medicine. These include, healthy nutrition, exercise, stress management, social support, sleep, and avoiding risky behaviors like smoking tobacco and consuming excess alcohol. Adherence to the 6 pillars is expected to reduce the risk of both mental and metabolic disorders. So takeaway 1 from my humble presentation, accumulated evidence suggests that patients suffering with major psychotic disorders such as schizophrenia, bipolar disorders, and major depression have a higher risk of developing metabolic syndrome, including weight gain, obesity, hyperlipidemia, hyperglycemia, and insulin resistance, which in turn will increase the risk of cardiovascular disease, stroke, and diabetes. Antipsychotic drugs, particularly the second generation, I had listed at the bottom of one of the earlier slides, or they are also known as atypical antipsychotics, have been proven to be the largest contributors leading to such metabolic disorders. And hence, switching to an antipsychotic that is less likely to cause metabolic disturbance, starting statin therapy, and reduction in CVD risk factors through changes in lifestyle may all be important strategies to mitigate both metabolic syndrome and mental disorders. So thank you very much for your patient hearing. If you have any questions, comments, criticism, everything is welcome. Thank you.
The forum is open for the questions. Any questions from the delegates?
So I have a couple of questions to ask to
Yes,
sir.
sir.
First of all, congratulations, fantastic
Can I-
presentation.
can I also
Yes,
take
please,
one?
sir, please. So you have displayed the physiology very beautifully of how this happens. So my question to you is a little practical one. Out of the commonest used questionnaire for assessing the mental health status, there's some like ITQ and the PHQ-9. Which one is the best in assessing the mental health status in a patient with PHQ-9 in
it is more
dysglycemia? And
clinically
second question, yeah, it's more sort of elaborate,
Elaborated,
yeah.
yes.
The second question is, how do you clinically differentiate an MDD from diabetes distress?
Can I differentiate a pure mental
MDD from diabetes distress,
So,
depression?
I mean, I have looked at the overlap rather than, I have not attempted to distinctly separate the two, but having said that, I have enumerated few features of classical depressive symptoms or schizophrenia, bipolar disorders. So I think the symptoms would guide me into suspecting a major mental issue rather than just a metabolic issue. But at the end of the day, the overlap is so stunning, and you and me, both of us practice in the same field. So I'm sure you will agree that many of our diabetics, they're diabetes distress, diabetes burnout, and then they have diabetes depression. So if you permit, I have one more slide after this. Can you just, yeah, I'll just, I need to unhide that. I have the time. Can you unhide this slide? ये वाला last one. Unhide कर. Put it on full screen.
It's visible now. So you can see.
Okay. Yeah, if it is full screen, it's better. Yeah. So I have just labeled it 3D for the sake of, I had hidden it. But then diabetes distress is a natural reaction to managing diabetes. It can include negative emotions like frustration, guilt, sadness, worry, anger, and feeling like one is not taking enough care of oneself. If these feelings persist for a long time, they can develop into diabetes burnout or later on to depression. So what is diabetes burnout? A state of physical or emotional exhaustion caused by ongoing distress of diabetes and effort to manage it. People with diabetes burnout may feel overwhelmed, helpless, and disengaged from managing their diabetes, which can lead to behaviors like skipping insulin, for example, doses, or not taking their medicines regularly. And finally, depression, a mental health condition that can cause a constant low mood that impairs daily functioning. Symptoms include, now this is partly answer to your brilliant question, Dr. Amit sir. Symptoms include feeling of sorrow, hopelessness, worthlessness, fatigue, difficulty concentrating, loss of interest or joy, increased irritability and guilt, poor sleep, poor energy and appetite, and thoughts of death or suicide. So thank you very much. Sir. Thank you. Yeah. Further question? Yeah, please, sir. It was a privilege meeting you in Delhi. So
it's my privilege also. So basically, particularly in the post-COVID era, there is a change, particularly the PCS, post-COVID syndrome, which encompasses both metabolic disarray as well as mental disarray. So, and at the same time, the changes in the gut microbiota, particularly after after the COVID. So, are you feeling, is it your opinion that we are going to get more number of patients who have
Both.
One
agree.
starting with the limb of gut dysbiosis, therefore mental disorder and diabetes, metabolic disorders, and others starting from the chronic inflammatory process, diabetes and mental disorders. So is it something which is a tip of the iceberg we are now facing?
Yes, I agree with you. That's a correct way of describing tip of an iceberg. I believe post-COVID and most recently, just 3 days ago, a new definition of long COVID has surfaced.
Yes.
If you Google, you will find it. So long COVID is now a reality, and it's, as you correctly said, the COVID virus not only caused ARDS or lung injury, but multi-organ issues, including direct beta cell,
apoptosis.
Yes, apoptosis, it aggravated that, and some form of toxic effect on the pancreatic beta cells. So many pre-diabetics or borderline hyperglycemics were turned into frank diabetics during so we saw a surge of newly detected diabetic patients post-COVID. I'm sure all of you have seen that.
And I think there should be at least epidemiological data for our country also, that particularly the metabolic liver disease, these patients, how much of these patients also going to land up not only in frank metabolic disorder, but also NFLT2 having coincidence of mental disorders.
So many, I'll give you a recent example. The controversy regarding the vaccine which all of us have taken, 3 shots, I have also taken. People have gone crazy. And they have bombarded us with all sorts of questions. What is going to happen to me? How did you suggest even putting a finger at us?
Yes.
But that's fine. We have to, as one of the brilliant previous judges said, that there is a great difference between negligence and, you have put in a genuine effort and you are not at fault. So I think, and you also touched upon the microbiome, which is a big deal. You will find any number of papers being churned out, genuine, brilliant papers, connecting dysbiosis with metabolic syndrome, with mental issues, and that has a trigger in form of previous COVID infection.
Yes.
So I agree with you. We are going to see, unless we do something dramatic, we are going to see an upsurge of both metabolic disorders and mental issues, especially in patients who have suffered previously with COVID infection.
Thank you.
Thank you so much. Thank you, sir.
Thank you, sir. Last question, I think I'll bombard you from my end. Sir, in our diabetes practice, how comfortable you are to assess the mental health of the patient? First is because we have a less amount of the time to assess the clinical patient. So what is the criteria based on which you think like these patients should be further analyzed for their mental health?
That's an excellent question. I think you, unfortunately, I am not as busy as my bosom colleague Amit is. I have enough time, so I spare my time for my patients. Proper conversation, and it's I am everything packaged into one for most of my patients. I'm a diabetologist, I'm a dietitian, and quite effective counselor also. But that will come only when you have the time to spend for your patient. But quickly, if you want to assess, the moment the patient walks into your chamber, looking at that patient's face, how he or she greets me, even if it's an absolute new case, how comfortable he or she is, how worried, anxious, or if she is doubting that the new doctor is going to run me through a unnecessary battery of tests because of, again, the media issues. So I think you can make a fair assessment, and then when you converse with the patient will say, "Neend nahi aati hai, aadhi raat tak main jagta rehta hu, and my wife snores. That's why I can't." So then you can identify, something amiss in the couple relationship. So, and erectile dysfunction is a major issue which has never been spoken about. But patients who we sometimes ask in an appropriate manner a very leading question to our male patients, and also in a very polite and appropriate manner to some of our female patients also. Because female sexual dysfunction is also at the root of discordance in marital life and appearance of depression. Okay. Thank you.
Excuse me, sir. In this, sir, I'm Dr. Shanmugavelu.
Yes, sir, yes.
So we have in our center, we have appointed health counselors.
Yes.
They are master's degree. They normally assess the mental illness of particular patients, and they normally give us a guide. Such patient has to be referred to psychiatrist for opinion. So they choose. They have their common set of questions, and most of these students from various colleges, they come to us. They take training in our center for not less than 3 months. They sit with the patient, they interact with the patient, they assess the psychological. So it is easy if you employ 1 or 2 such postgraduates.
Sir, but how comfortable the patients are there to accept like they are in depression in
so
stress?
when you spend maximum time on that particular health, they'll be in a better position to interact with those.
Very
It's like a
properly.
Pandora's box, we open it up.
Last comment, sir. Yes, Pandora's box. That's the right term. I totally agree with you. Ji, sir. Yes.
So if we get hold of them and keep in our clinic and get it filled under the supervision of somebody,
मिलता है आराम से.
that will help us. So most of them are score based actually.
So ideal diabetes team is not just me, my dietitian, my diabetes educator, a counselor, even a podiatrist. So that makes a perfect team. Having said that, we have been very aptly helped by pharma companies. I don't want to name them, but they are standard pharma companies who don't expect us to promote their products just because they are rendering that service. They come with that questionnaire in a very proper. They are all trained boys, as Dr. Saab said. All trained boys or girls, and especially when the young girls are there, they are able to dig out very effectively all the issues. So we are helped in that manner. So thank you very much.
Thank you, sir.
Thank you.
The next speaker is Dr. Ghanshyam Goyal, sir. He will be speaking on diabetes food complication, multidisciplinary approach to prevent and the treatment. Dr. Ghanshyam Goyal, sir, is a senior diabetologist and a diabetes food specialist. He practices at ILS Hospital, Salt Lake, Kolkata, and he is a secretary and Integrated Diabetes and Endocrine Academy. He has received multiple awards as well as he has presented in all national and international conferences. Apart from it, sir is also a principal investigator in multinational trials. Sir, I hand over the podium to you, sir. The ball is in your court.
Thank you, Chairperson, sir, for kind words. Today, what I'm going to do is a very simple and basic presentation on diabetic foot. So, my topic is 2 parts. One is prevention and another is management. So, basically, I'm going to discuss about the prevention because in this 20 minutes of time, probably I may not do the justice with the topic. So, what are the complications of diabetic foot? We all know. Diabetic foot ulcers, which may be neuropathic, ischemic or neuroischemic, or Charcot's neuroarthropathy, Charcot's foot we all know, or amputation, maybe minor or maybe landed with a major amputation, maybe below knee or above knee. So this is a famous slide I think everybody in this August gathering have seen, that DFU prevalence is increasing as persons with diabetes live longer. One. Second, people with DFU are at high risk of lower extremity amputation, especially young, racial, ethnic minority, and low socio-economic strata group. Better diabetes preventive care is necessary to decrease incidence of diabetic foot ulcer and lower extremity amputations. We used to say there is a lifetime incidence of around 15%, then we used to say around 25%, but there is a recent data. Around 34% of the people in their lifetime are going to develop diabetic foot ulcer. Means out of 3, 1 is going to develop diabetic foot ulcer in their lifetime. This is the important aspect. This is another paper by the Dr. David Armstrong and Andrew Bolton, and what they have shown, same, the 4% of the incidence, and very important, people with a healed foot ulcer, for 1 year, recurrence rate is 40%, 3 years is 60%, and 5 years is up to 80%. So means we should use the term ulcer is, I can say, healed or recovered. No. We should use the word that your ulcer is in remission. Just like we use the cancer for the, it's in remission. So we have to use the word remission. So your ulcer is in remission. So this is the cost of diabetes. You can see breast cancer, colorectal, lung cancer, prostate cancer, leukemia. All these 5 cancers are having more cost, less costly than the diabetic foot. So you have to remember it. And even 5-year mortality is more with the diabetic foot than these 5 common cancers. So who is at risk of ulceration? Everybody knows. Neuropathy, peripheral vascular disease, microvascular complications, poor glycemic control, smoking, foot deformity and amputations. So what is the typical, I think each and everyone in this August gathering used to see these sort of patients, just ulcers, you can see the unilateral ulcer, and remember it, out of all the ulcers, 1/3 of the ulcers occur at the great toe, 1/3, and rest, 1st, 3rd, 5th, empty heads, heel area and other areas. So this is 1/3. Unilateral ulcers, you can say heel ulcers, we say it's difficult to heal or they never heals. Patient just goes and lost his life on account of the other complications, that the CV complications or renal complication, and this is the non-healing ulcer, it's a neuropathy because lot of callus is there. To callus to grow, you require a good blood supply. If there could have been not a callus and it is on high pressure area, so it's a neuropathic ulcer. Then unilateral ulcers, bilateral. Bilateral is the biggest problem because it is very difficult to offload them. This is the most common problem and difficulty we face. If it is a bilateral ulcer, great toe, it's difficult to offload them. So that's why it's very difficult. And this is the bilateral first empty head ulcers. You can see. This is infected. You see. This is not only limb threatening. This is a life threatening sort of infection. You see, in this patient, immediately a multidisciplinary approach, as Dr. Vinod was discussing regarding all these issues, teamwork. In diabetes care, it's teamwork. A single person cannot do anything. Then, after seeing all these cases, we see in our day-to-day clinical practice, most of the cases which I have shown have been prevented. It is not like that it could have not prevented. To prevent TFU, we have to also understand and address the challenges and barriers to the foot care. Simply, the common scenario, unsuccessful home therapy, visit to local physician, application of unproven remedies. Second, visit to primary care center, district hospital, regional hospital, not aware of diabetic foot leading to sepsis because of delays. Then, referral to specialist care, which has already been delayed. And in most of these patients, the ulcer has gone progress to the gangrene and maybe result with the poor outcome, maybe minor amputation or maybe major amputation. And challenges are different from the different countries. Barefoot walking, this is very common. We see at least during the hot summer days, lot of cases. And during this, I'll say, month of Shravan, people go barefoot, walking and do that. And because they've got a lot of protective sensation is there and they landed with these sort of problems. Then sleeping in the open, this is very common, especially the rural areas, and rat bite is a very common scenario which is very important. Use of antibiotics without proper prescription, because there should be rationale. And always remember, if a patient whose ulcer is not infected, antibiotics are not required. If it is infected, then only. It's mild, moderate, severe. I'm just going to have slides, so I'll show you. Then about the prevention, because I'm going to focus more on the prevention. There are 5 key elements that underpin prevention of foot problems. So identify the at-risk feet, that is at the physician's level, that we have to, whenever a patient, I always say, even I remember Dr. Velu called me around before COVID, and we have conducted a workshop at his place and at Trichy. So the same thing, identify at risk is the most important thing which the physicians can do. Just look for it. Is there a loss of protective sensation or not? Is it a high risk, means mild, moderate or severe? You can say low risk, high risk, very high risk, just like that. We can divide. So this is a very simple thing. Regularly inspecting and examining the at-risk feet, education of the family, of the patient, and the healthcare professionals. All is to be given, that is very important. And ensure the routine appropriate footwear, treating risk factor for ulceration.